The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies. But I could. Big Pharma, where you at? But, alas, I have no financial disclosures. Okay, on with the show. Hey, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. I want to talk about kidneys today, more specifically kidney function, and how we measure that and think about that and deal with that in clinical practice. I'm trying to get better at this myself in my own practice and make sure that I'm paying enough attention to what people's kidney function is doing over time. I'm sure it's not like this in all clinical settings, but pretty much everywhere I've had personal experience with, the very down and dirty version of how we pay attention to kidney function is we look at the creatinine, and if it's okay, then the kidney function's okay. And there's really so much more to it than that. Obviously, there's a whole specialty called nephrology, and that generally means there's a lot more to it than a person's simple personal script for how to deal with an issue like that. So I want to just review the basics and some of the tools that are available to us to help assess this and risk stratify patients in order to figure out who we need to be paying more attention to or doing more about or doing less with in some cases if we need to take away medicine that would be harmful to kidneys. In my community where I practice now, there's only one nephrology practice. So I try really hard not to overwhelm them by sending every person whose creatinine bumps to get established with them. I was actually talking to one of the people who works there, and she said, we have a lot more primary care nurse practitioners in town now, so we're getting a lot more referrals. And I was like, I'm not sure how to take that. I guess it's good that people are paying attention to their patient's kidney function. And obviously, this is one person's anecdotal comment about that. But I do see that my physician boss is a bit less freaky outy about kidney function than I am. So maybe that is a difference. Maybe physicians in general are more comfortable managing patients and letting their kidney function decline more before they pull the trigger and send them to a specialist. I don't know. That's very anecdotal. I would rather err on the side of caution with something like that. But again, you have to know the resources in your community, and I don't want our one nephrology practice to start rolling their eyes every time they get a referral from me, knowing that it's for somebody who has a creatinine of 1.1 that's going to be fine for the next 20 years or whatever. So I'll talk a little about how I'm thinking about that these days. But first, I'm just going to talk about the very basics of looking at kidney function. Of course, the things we think about when we look at a metabolic panel when we're considering kidney function are the BUN and creatinine. BUN stands for blood urea nitrogen. That's a waste product of protein metabolism that forms in the liver and then gets excreted by the kidneys. So when you're measuring the level of BUN in the blood, you're seeing the balance between how much is being produced and how much is being gotten rid of by the kidneys. If it's elevated, we call that azotemia, and that's when you get into the whole pre-renal, intrinsic renal, or post-renal azotemia situation, which are really big words that come down to, is the problem somewhere in the chain of organs before you get to the kidneys? Is the problem with the kidney itself, or is the problem somewhere in the outflow tract of the kidneys? You can also have the BUN be low, which typically means that you're not getting enough protein metabolism for some reason, or I suppose it could mean that you have super duper efficient kidneys, but really we think about liver disease being the main problem there, so there's not as much urea nitrogen being produced. Also, obviously, if you're malnourished, not getting enough protein in your diet. If you're overhydrated, this could be a dilutional, low BUN kind of situation, or you see that with pregnancy also. The big one, as I said before, or alluded to before, that people pay attention to for kidney function really is creatinine. If you're going to just glance at one thing on a metabolic panel to get an idea of the kidney function, it's going to be the creatinine. This is another waste product. It comes from metabolism of creatine and phosphocreatine in the skeletal muscle. It's a good marker of kidney function because it gets produced at a pretty constant rate. It's very freely filtered in the glomerulus, and it's mostly not reabsorbed or secreted by the renal tubules. So it's a pretty stable marker of the GFR, or glomerular filtration rate. I'll just go ahead and define that since I brought it up. That is the rate at which the glomeruli, which are the little functional units of the kidney, are actually filtering the plasma. On a little bit deeper level, it's actually the product of the number of functioning nephrons and the average single nephron GFR. So if you start losing nephrons, the ones that are still working can compensate for that by filtering more rapidly, by working harder. So that's the thought behind considering how well is one nephron working and how many functioning nephrons there are. This is something that generally is calculated. So if you're looking at a GFR on a typical metabolic panel, or if you're doing that calculation yourself, what you're coming up with is the eGFR, or estimated GFR. If you need a more precise GFR because you're in some kind of weird situation, like we're talking about somebody's being evaluated to donate their kidney, or we need to really know about kidney function for chemotherapy dosing, there is a measured GFR, or mGFR, in which you can actually measure the clearance of specific filtration markers. The standard there is inulin clearance, although it seems like the most widely accepted now is iohexol plasma clearance. I don't think I've ever been in a situation where that was done. I'm not working with transplant patients or figuring out chemotherapy dosing. So really every GFR I see is going to be an estimated GFR, eGFR. By the way, I just want to point out that I'm not smart enough for nephrology. If you read even just a routine nephrology note, they track a lot of stuff. There's a lot of numbers going on. They're very dense, thick notes. I have a feeling maybe it is a bit cookie cutter once you get into it and understand it and know what you're doing with those patients, because it's a lot of math and a lot of numbers. But I feel like that's one specialty that I'm just not qualified for, as evidenced by my declining performance in Neph Madness every time I do it, perhaps. But I just want to say hats off to my nephrology colleagues locally and everywhere else too. You guys are smart. I really like Dr. Joel Toff, who shows up on medical podcasts a lot. He and his group of people do their own kidney podcast called Freely Filtered. And I've tried to listen to it a few times, but y'all, it's so far over my head. I'm just I'm not getting anything out of this. I like it when he comes on the Curbsiders or some of the other podcasts and it's like, let me just use regular words to talk about this for you primary care people. I feel the same way about hematology and oncology. I just went to the local Cancer Institute's annual CME update course that they provide, which is excellent. There's always at least one session there that just blows me out of the water. I have no idea what they're talking about. And I feel like an idiot sitting in the room with mostly hematology and oncology providers. So I just put my head down and keep my mouth shut and try to learn something. So, okay, we talked about BUN, we talked about creatinine. One thing that shows up on metabolic panels is the ratio of BUN to creatinine. And that goes back to the whole pre-renal versus intrinsic renal problems. If you have an abnormality, if the ratio of BUN to creatinine is greater than 20-1, that suggests a pre-renal cause of azotemia. And that could be any of a million different problems that happen before you get to the kidneys. You could be talking dehydration, heart failure, shock, GI bleeding, or even just eating a lot of protein. That would be a very wide differential on that. The normal ratio should be about 10 or 15-1. And then if your ratio is less than 10-1, now we're talking about intrinsic kidney or liver disease. And this is something that flags as abnormal a lot, even if the BUN and creatinine are both within the normal range. It's one of those things that I sort of wish was not on every lab result, because it's one of those things that you tell the patient everything's fine, and then they go, what about this? Why is this in bold? Why is this flagged? It's not super useful in isolation, I would say, but really only if you recognize there's a problem and you're looking for the cause of that problem is that ratio super helpful. Circling back to creatinine, I think it's important to understand the limitations of creatinine and things that can affect it. Probably the most important one to consider is muscle mass. So remember that creatinine is generated from the normal metabolism of things that are in the skeletal muscle. So if somebody has more skeletal muscle, so we're talking about bodybuilders, very athletic people, their baseline creatinine level is going to be higher because they have more muscle tissue. And we've run into that before where a young, healthy, very muscular person thinks they have kidney failure because their creatinine's up. And it's easy to fall into that. You have to remember, no, wait, your baseline is probably different than mama who hasn't moved in 3 years, right? And similarly, you're going to see lower creatinine in people who are cachectic, elderly, have very low muscle mass. People who are amputees, I can't say I've ever really thought about that before, but obviously if you cut off somebody's leg, especially, or both legs, you're losing a lot of muscle mass. So it makes sense. So you have to really keep in mind who you're looking at when you're assessing the creatinine level. So where that would be more important is if you do have a emaciated, cachectic kind of person and the creatinine is in the normal range, well, really you would expect it to be low. So that could indicate significant renal impairment, even though the number itself is normal. Diet affects this. If you eat a bunch of meat, you're getting a big load of creatine. So you can see transient increases in the serum creatinine because of what you're eating. I've definitely seen this happen too in people who are taking creatine supplements. Usually these are younger people who are working out, trying to build muscle. So if you get a high creatinine that you're not expecting, that's definitely one thing to ask about. Hey, are you taking any supplements? You doing any creatine? Because that will affect the lab. There are some medications that inhibit the tubular secretion of creatinine. So those will raise your serum level, even though there's not been a true change in the GFR. Trimethoprim is probably the most common. Cimetidine is another one. Some different antiretroviral medications can do this. Fenofibrate. There are a few others listed that are way less common. We've definitely seen that with that new non-steroidal mineralocorticoid receptor antagonist, finerenone, brand name Corindia. I haven't used a ton of it, but one patient I put on it, that creatinine went through the roof, freaked me out, and I stopped the medicine and sent him to the nephrologist. And I don't really have an explanation for that. That would be a nephrology question. Pretty much all they did was just not put him back on the medication, and now they're just monitoring him like any other nephrology patient. But always important to think about whether medication might be affecting your kidney labs, and especially important because one of the big things you can do to help prevent somebody's kidney function from getting worse is just not have them on medicines that can screw up their kidneys. Of course, there was a big idea for a long time that race or ethnicity affected somebody's serum creatinine, which led to people getting screwed over and not put on the right place on the transplant lists. In 2021, they took race out of the big equation that everybody uses to calculate GFR. And I've said this on the podcast several times before, anything that's race-based just seems shady. I'm always very skeptical of anything that's like, oh, this is better or worse in Black patients. You gotta be real critical of those kind of things that persist in medicine, because maybe it's true or maybe it's the product of bias in medical research. We don't know. So when the creatinine's elevated is generally when we start freaking out about kidney function not being good. We use the terms AKI and CKD. AKI meaning acute kidney injury and CKD meaning chronic kidney disease. So if somebody gets super dehydrated, goes into shock from something else like a pre-renal sort of cause, they go into the hospital, they're super sick. It's not uncommon for their kidney function to be off, and then once they're rehydrated or the problem's fixed, it goes back to normal. So that's what is referred to as an acute kidney injury. CKD, of course, is a more stable, long-term decrease in the GFR. There's another value that you see float around sometimes called creatinine clearance. This is the volume of blood plasma that's cleared of creatinine per unit of time. So it's just sort of a slightly different way of looking at what the glomerulus is doing or how fast it's working. However, that reflects both glomerular filtration and tubular secretion of creatinine. So the creatinine clearance sort of overestimates the true kidney function. According to my reference here, it overestimates true GFR by 10 to 20%, which is really not what you want if you're trying to be careful about not giving someone too much medicine because their kidneys don't work. This is a thing you can measure from a 24-hour urine collection. Typically, of course, we're going to come up with an estimated creatinine clearance by using the Cockcroft-Gault equation. You see that show up a lot when you're trying to adjust drug doses for a person's kidney function. A lot of times when you look up renal dosing of a medicine, it's going to tell you how to change the dosing based on the patient's creatinine clearance. It seems like there are a lot of limitations to that creatinine clearance and that Cockcroft-Gault equation. Here's something a little shocking from New England Journal of Medicine. This Cockcroft-Gault equation was developed in 1976 from 249 men, period. I would have guessed that was a hugely validated millions and millions of patients and years of studies and blah, blah, blah. But sounds like Dr. Cockcroft and Dr. Gault maybe just threw that together a little bit. There are several other limitations of that are listed as well. So the current recommendation is really to go more by the GFR based on the most current equations to calculate that when we're thinking about kidney function. So maybe we'll see that creatinine clearance become less of a thing as time goes on. Okay, again, circling back to creatinine, it's not perfect for looking at kidney function, going back to the kidney's ability to kind of kick the working nephrons into overdrive when you start losing nephrons. You can end up with a situation where the creatinine is not changing until the GFR has declined significantly. even up to 50%. That's called the creatinine blind range. There's another biomarker called cystatin C that is less dependent on a person's muscle mass. This is a low molecular weight protein that is produced at a constant rate by all nucleated cells and is also freely filtered by the glomerulus. It is not affected by muscle mass or diet. There's no stupid race association to overcome there, and it is more sensitive for detecting mild reductions in GFR. It can be affected by a few different factors, including smoking, obesity, inflammation, thyroid disease, malignancy, and steroids, as in somebody taking glucocorticoids. This is not something I've started using in my practice, but I do keep it in my back pocket. If there was ever a situation where I was extremely worried about a patient's kidney function, even though the numbers were still normal, if someone was particularly high risk, or if there was a muscle mass issue, that would be a time when I would consider ordering the cystatin C in addition to the normal stuff on the metabolic panel. Other times when it might be good to use it would be if you're very close to deciding that somebody has CKD that is bad enough to warrant sending them to a nephrologist. If a person is larger, so BMI over 40, if they're on one of those medications that can affect tubular secretion of creatinine that I mentioned earlier, or in one of those other situations where it's very important to know the precise kidney function. Okay, so we've talked about BUN, creatinine, cystatin C, creatinine clearance, and GFR. I would say that GFR is the most important of all these things. So how do we come up with that? Ideally, it appears on your metabolic panel. In our lab, this was not the case until recently. They just got a new machine that calculates the GFR, but previously all we had to look at was BUN creatinine and the ratio of those things. If we wanted to know the GFR, we had to calculate it ourselves, which is not super conducive to efficiency and accurately looking at people's kidney function. So I'm glad that is printed on our lab results now. Most other places I've been, I think the GFR is just standardly on there with the metabolic panel. The current recommendation for how to calculate the GFR would be the 2021 CKD-EPI equations. These equations have had race removed as a contributing factor. I use MD-Calc for this, and when you pull up the equations for GFR, it lets you choose which one you want to use. The top one, which I assume would be the most common, is the 2021 CKD-EPI equation, which requires you to put in gender, age, and serum creatinine. The second one on the list is also from 2021, but it also wants the cystatin C as well as the serum creatinine. And then you can pick still from the older equations from 2009 and 2012. I don't know why you would want to use one of those older equations. The one from 2009 still includes the patient's race. The calculator that I used to use through Hippocrates was weight-based, so you would get a GFR estimate based on that patient's weight. That is not the case with the most current ones. You don't put in a weight, so the result that you're getting is in units of milliliters per minute per 1.73 meters squared of body surface area. So once you get that number, what do you do with it? So here's something that doesn't make a ton of sense to me. The staging for CKD, for chronic kidney disease. A GFR above 90 is considered normal. If you plug in your numbers and you get that result, let's say the GFR is 110, it's going to tell you that that's stage 1 CKD, which I think is just misleading. I think the whole terminology of kidney disease staging or CKD staging is very misleading to people. Patients for sure, but clinicians also. Because to me, if your GFR is normal, that means you don't have chronic kidney disease. It's not stage 1. It's you don't have it, right? I mean, if you call someone pre-diabetes, that means their glucose is higher than normal. If you tell someone they have stage 1 cancer, that means they have cancer, right? But anyway, whatever you think about that, as the GFR declines, your stage of chronic kidney disease increases. So stage 2 is a GFR of 60 to 89. Stage 3A is 45 to 59. Stage 3B is 30 to 44. Stage 4, 15 to 29. And stage 5 is 15 or less. I have heard people say that they don't really think anything above stage 3 should be considered CKD at all, and I agree with that. I had a patient just the other day, we were talking about kidney function. He said, I want to make sure that you're checking my kidney function and paying attention to that. He said, my dad had chronic kidney disease and they didn't even catch it until it was in stage 3. And so that's partly a knowledge deficit, right? It's not really a problem until it's stage 3. Really, in my mind, it's stage 3B where you go, okay, there's a problem now. But you can understand why a patient might think that, like, oh, why didn't you tell me I had this back when I was in stage 1? Which is exactly why I think this nomenclature is stupid and weird. I wanted to look a little bit into the history of how they developed these stages of CKD, and I was surprised at what I found. Pretty much before 2002, now I'm old enough that 2002 doesn't sound like that long ago to me, but I would have thought this would have been the case like back in the 1950s or something. I mentioned that Cockcroft-Gault equation came along in 1976, but really before 2002, pretty much what you did was what I said at the beginning of the episode. You look at the creatinine, and if it's okay, then the kidney function is okay. The first equation that came along to estimate GFR directly was called the MDRD equation. That was in 1999. I graduated from high school in 2000, so that was like just yesterday as far as I'm concerned. But that's when that sort of came about. How about that? The first formal CKD staging system was developed in 2002. That's when I was finishing paramedic school. This is the NKF-KDOQI. That stands for National Kidney Foundation's Kidney Disease Outcomes Quality Initiative. And that's where that 5-stage classification based on GFR level came from. There were many shortcomings of that initial system. And so in 2009, KDIGO, which is Kidney Disease, Improving Global Outcomes. That's an independent nonprofit established by the National Kidney Foundation. In 2003, that's when I started my first paid paramedic job. So they had a conference in 2009 and published some data to try to adjust the equation a bit. They did that again in 2012. That's when they split stage 3 into A and B subtypes. At that time, they also added albumin into the mix, as well as recommending that the underlying cause of the CKD be considered. Most recently, they have updated things in 2024, which is when they officially recommended this CKD-EPI race-free equation for calculating GFR and endorsed adding cystatin C. And they're emphasizing using individualized risk assessment tools, which we're going to talk about next. Fascinating stuff. I'm having a realization, and you're hearing me learn this and think about this for the first time in real time. The doctor that I work for and I are the same age, so people my age were trained by a generation of physicians who were trained when GFR was not even a thing. And we know that it generally takes 20, 30, 40 years for things to catch on in medicine. So it makes a lot of sense why there's this pervasive thinking that you just look at the creatinine and as long as it's okay, the kidney function's okay. That totally makes sense. How about that? This is cutting edge stuff we're talking about here, people. I didn't even realize that. We're on the cutting edge here at Knowledgeable Provider. Okay, so risk calculation. This is something that I am trying to incorporate more into my practice. Of course, for cardiovascular risk, but specifically now for kidney failure risk as well. The tool that I use and that is recommended is the kidney failure risk equation, KFRE. That gives you an estimate of a person's 2-year and 5-year probability of kidney failure requiring dialysis or transplant. And that applies to individuals with a GFR less than 60. This risk calculator ain't no Dr. Cockcroft and Dr. Gault having a drink at the bar and writing it down on the back of a napkin. This was developed in 2011 from the Canadian CKD cohort. It's been validated in over 2 million individuals across 60-plus cohorts from nearly every continent. There are 2 versions. There's a 4-variable and an 8-variable equation. The one that I use is the 8-variable equation. And I did not know that there was a 4-variable equation. I wonder if that's in MD-Calc somewhere. The only one that I can find in MD-Calc is the 8-variable equation. So that's what I've been using. The 4-variable one, you have to put in age, sex, GFR, and the urine albumin to creatinine ratio, which you get hopefully on a urinalysis. We have to order it separately with ours, but it's on the same form as the urinalysis results. The 8-variable equation that I've been using is those things plus the serum albumin level, the phosphate level, calcium level, and bicarbonate. On our labs, one of the units of measurement doesn't match what's in the MD-Calc equation, so I always have to be careful and change that. I think it's the bicarbonate level. Remember that bicarbonate is often labeled as CO2 on the metabolic panel. That's one of my favorite little pearls to tell students about. Maybe my shining moment as a student in any capacity of all the different times I've been a student happened when I was doing a rotation for practitioner training with the trauma service. And it was me and a resident physician were the two quote unquote students that were with them that day. And we were with Dr. Najjar, who's a legendary trauma surgeon around here. Fantastic teacher, fantastic surgeon. He was asking us about this somehow, and this idea of bicarbonate came up. And I knew that the bicarb was the CO2 on the metabolic panel. And he challenged me. Dr. Najjar challenged me on it. He's like, what? It doesn't say bicarb. What does that mean? Can you explain that? Of course, I'm like withering under this man's attention. I'm like, oh God, like I knew I was right, but I couldn't exactly come up with the words to justify why I was right. And I kind of like melted. And so he turns to the resident and he's like, can you explain this? And this poor guy like rattled off some words that I should have said about blah, 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 blah. But he was saying that I was wrong. He was like, and that's why it's not. And I got to be right. I got to be right. I wish I had been able to back up my knowledge a little bit better, but oh, that made me feel so flipping good. So anyway, yeah, it doesn't say bicarb on the metabolic panel. It's the CO2, but it's the same number. It's been a little bit tricky to incorporate this into my daily routine because I have to remember to order the phosphate for people who have CKD to do this calculation with. Of course, the other variables are just part of the regular metabolic panel. The equation is actually not validated for people with GFRs above 60, which would be quote unquote stage 1 or stage 2, which to me says also that it's stupid to call that stages of kidney disease. But anyway, there you go. So for people who really have chronic kidney disease, use the kidney failure risk equation. The general recommendation is to refer people to nephrology if they have a 5-year kidney failure risk between 3 and 5%. And just anecdotally, I have seen that seems pretty reasonable. It's not like the Chad's VASC score where it's like, let's see if this patient is going to be a candidate for anticoagulation. Spoiler alert, yes, they are. This equation is not like that. It really does seem to give you a pretty reasonable picture of a person's risk of going into for real kidney failure. I would definitely err more on the side of waiting till we get to 5% or more, since again, I only have one nephrology practice in my town. Importantly, JAMA points out that this KFRE is not meant to replace other traditional criteria for referring people to nephrology. Those would be GFR less than 30, urine albumin creatinine ratio greater than 300, rapid GFR decline, so greater than 5 in a year, unexplained hematuria, refractory hypertension, or suspected glomerulonephritis. So like all these clinical calculators, it's not meant to replace our clinical judgment. It's just meant to help complement what we're doing and thinking anyway. Okay, I think we've reached the end of what I wanted to say about kidney function. I have learned things from doing this podcast. I always do, but I feel like I've learned more than usual from doing this episode. So I hope it was helpful for you as well. There's a lot about kidneys I probably don't know. So if I said anything wrong, if there's anything you would like to contribute, anything important that I missed, please feel free to get in touch and let me know. If you haven't checked out my book, my novel, please do that. It's called Crooked Creek Serenade, written under my own name, Jody Marks. I put out an official video trailer thing about it in the podcast feed and on my YouTube channels and on my Facebook pages. It's available from pretty much any online retailer of paperbacks, ebooks, or audiobooks. I'm very proud of it. It was a labor of love. It was very much a passion project sort of thing. I would really appreciate it if you would buy a copy and read it or listen to it and then leave a nice rating or review. I feel like if maybe 500,000 people buy it, then I can quit my day job and just focus on doing podcasts and writing. So if my math is correct, that means I only need to sell about 499,970 more copies. So let's get going on that, folks. As always, thank you for listening to the podcast. I hope that you have a great week, and I will talk to you later. All right, that does it for this episode of Knowledgeable Provider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, and subscriptions really do help the show, so please take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.